Okay, we'll go ahead and get started. We'll talk a little about rhythm review. And one of the things we want to start doing is talking about some of the fundamentals of rhythm recognition. There's a couple of ways that folks learn how to do rhythm recognition. And one of those is to just sort of memorize what an EKG looks like and then overlay that memory that you have on an actual EKG and try to match them up that way. And that works, but it doesn't work consistently and it doesn't work very well because all of us have some degree of variance in the morphology of our EKGs. And so understanding some of the fundamental concepts of rhythm recognition, what a P wave is, what a QRS wave is, and those things are very helpful so that you can have critical thinking ability to recognize rhythms. And somewhere in here, we're going to also talk a little bit about therapies, but we really want to focus on rhythm recognition. And we're going to talk a little bit about the conduction system of the heart. That's important to know just because some of the medications we give work in different places. And an EKG will look different depending on where it comes from. The heart is much like your fist, depending on from what angle you look at it, it will look very different. So we want to approach that. Systematic approach obviously is going to work best because if you do the same things every time, you're more likely to be successful. And then anything that you may have a question about, again, put it in the chat if I don't touch on it, or if there's some confusing terminology, or if I'm saying something that doesn't make sense. So kind of our outline here, framework is going to be talk about a systematic approach. We're going to break down a rhythm strip. What is it? Talk about the electrical system of the heart. And then we're going to talk about the various rhythms uh, from normal rhythms to blocks and lethal rhythms last. And again, as Lucian mentioned, if you have a question, put it in the chat box. I'll try to answer those as we go, unless that so we can do them in context of either the slide or the type of rhythm that we're looking at. So rapid identification rhythm sometimes is very difficult. And for new folks, I would certainly encourage you, if you have at all the ability, if you're doing rhythm recognition, is to print out an EKG strip and actually look at a static strip on a piece of paper. Dynamic interpretation is very difficult and can be kind of confusing at times. And especially now that the hospital's gone to Zoll, you have but a few seconds of EKG on screen at any one time. And therefore, that makes it very difficult to interpret. So one of the principles I tell with the new Zoll transition is make sure you print a rhythm strip, several seconds worth of rhythm strip, so that you can actually look at the rhythm and categorize what it is and have this systematic approach. So the things we want to look at, we want to look at the rate. Is it regular or irregular? Rhythm. What is it? What's the morphology of the waves, the P waves? The PR interval is critical, especially when we talk about blocks. How the P and the QRS correlate, and then the QRS complexes. And the pacemaker here is not an implanted or external pacemaker, but rather the pacemaker that's driving the rhythm. So the rate, again, is it fast? Is it slow? Um, what are we looking for here, right? If we have someone who has a rate, what we know is the intrinsic rate of the SA node is between, depending on what book you read, 60 to 100, 110. And so are we outside of those parameters? Because it's going to mean different things in different rhythm types. So what may be normal in one rhythm may be fast for another. In other words, normal sinus rhythm at a rate of 70 or 80 is expected. However, if you're in a junctional rhythm, that becomes a rapid junctional rhythm or an accelerated junctional rhythm because the intrinsic pacemaker that comes from the AV junction goes slower than that. Is it regular or irregular? We talked about that. That means something to us. And all of this also does not take into account any type of ectopy. And we're not touching on ectopy today. That adds a degree of complexity to rhythm recognition. But what you should know is what's the core rhythm. PVCs, PACs, PJCs can add some confusion to your rhythm interpretation. The P waves, are they there? Are they configured normally? The PR interval, which should be between 0.12 and 0.20 seconds. How do you measure this interval? We're going to talk about that on an upcoming slide. And then this correlation, and then, as I mentioned earlier, the intrinsic pacemaker. What part of the heart is this coming from? So this slide has a lot of work here to do, and where we look at the P wave, and the way I describe rhythm recognition and EKGs is that it's a time map of electricity travel. And so what you would expect is a little bit of electricity, like the P wave, means that it doesn't travel very far and it's not traveling through a lot of muscle. Whereas the QRS complex here is a lot of electricity because that's a larger part of the muscle that and a further path that it follows to execute its contraction. So understanding intrinsically what an EKG is, it's a time map of electricity travel. And various things disrupt conduction and the time it takes for electricity to travel. One of the examples, again, not some of the things we're going to touch on today, but we talk about STEMIs and ST elevation. And the reason that's so significant is that when blood flow is impaired to a particular part of the heart, then that changes the cell's ability to conduct electricity. And that's where the ST elevation component comes in and factors in. So understanding some of these foundational principles will help you with rhythm recognition. So the P wave is the atrial firing. The PR interval, as we see up here, from the beginning of the P wave to the Q wave to the beginning here, is the travel time from the SA node to the AV node to the activation. And the QRS firing is the ventricle contracting, depolarizing the ST segment again. Here, followed the T wave is when there's absolute repolarization of the myocardium. And then here's where we get really nervous when folks have ectopy, because if they have something called R on T, so if you have this happen here, then that can cause fibrillation. And that's one of those things that can happen when folks have heart attacks, for example, and they have something called R on T. It's also one of the reasons we synchronize when we cardiovert perfusing rhythms, because what we want to avoid is the heart is very, very sensitive during this refractory period. And if we do get an electrical impulse that conflicts with this period of time, then it can cause the heart to fibrillate. It's very fragile. So this is what we just talked about: atrial depolarization, ventricular depolarization. What we're looking for is this 0.12 to 0.20 seconds. And what we're going to look here is this measurement, the QRS interval right here in between. That's the 0.12 to 0.20 seconds. And remember, each one of these small boxes is 0.04, and the larger boxes are 1 second. Fraction, sorry about that. 0.04 for the small ones, 0.20 seconds. So just taking a quick little look at the heart and see what we see is with the conduction system, the SA node is the origin of normal sinus rhythm. That's the most common rhythm, obviously, in folks until you get over the age of 70. Then you see more atrial fibrillation as a primary rhythm, and that's just because this node starts to fail, doesn't work as effectively. This stimulates the right atrium, which gives us up to 10% in cardiac output improvements. So folks that are in atrial fibrillation lose about 10%, or the atrial kick, as they call it, when it comes to cardiac perfusion. The signal starts at the SA node, travels down the pathway to the AV node. This is also known as the junction. So junctional rhythms originate here because the SA node isn't working for whatever reason. They intrinsically go a little slower, so 40 to 60 may be the rates that you see with junctional rhythms. And then as we travel on down the pathway, the His-Purkinje system is where, and the final pacemaker of the heart, where the intrinsic rate, usually less than 40, a lot of times complete heart blocks originate down in the His-Purkinje system. Yeah, this is one of those things we just talked about. the ventricular, the Purkinje 5, that's the Purkinje system, and that's when both of those nodes, the SA and the AV node, have failed. So let's start with our first rhythm. Hopefully everyone will find this one to be relatively easy. What we're looking for is the P wave. Is it there? Yes. Is it there before each one? Do they all look the same? So, and the answer to all of that is yes. They look alike. There's P before every QRS. They're constant, they're regular, and this interval is acceptable from the beginning here to the beginning here is less than 0.20 seconds. The rate between 60 and 100, it's regular. So this is probably an SA node type rhythm. That's where it's originating, normal sinus rhythm. A variation of normal sinus rhythm is either sinus bradycardia or sinus tachycardia. Both of those occur for some usually physiologic reason, and that's a really important point for everybody to think about. Sinus bradycardia is one of the things, for example, in children we see as a primary cause is hypoxemia can cause sinus bradycardia. It's not the heart that's having a problem, it's something else that's causing it. In adults, sinus tachycardia can be caused by hypovolemia, it can be caused by sepsis, it can be caused by pain, fever, exercise. Any of those things can cause tachycardia. It doesn't mean that we need to treat the rhythm. We really have to, once we see a sinus rhythm or a rhythm that has a sinus base or origin, we really need to think of why is this happening? What are the physiologic causes of this rhythm? And we should not treat the tachycardia. In other words, if I'm in sinus tach at 140 because I just ran up the stairs, I probably should not get a dose of adenosine. That's my heart compensating. So keep that in mind. If you call it sinus, because it's got a P and a QRST and they all look normal, and it's not beating as fast as you would like or faster than you would like, then what you really need to do is look at why is this happening and the causes of it. So sinus bradycardia, absolute bradycardia is less than 60 beats per minute, and that's called sinus bradycardia. Relative bradycardia is a term we don't hear much of anymore, but it's an important consideration, and that is the patient's heart rate slow relative to what it should be? And this happens, we make a lot of reference to this, if somebody is on a beta blocker and they're febrile or they're septic, you may not see their heart rate become tachycardic like it should. It may be 80 and they have hypotension and signs of poor perfusion. Well, that in the clinical context, that paints a picture of a relative bradycardia because in the presence of those symptoms, we'd expect the heart to be compensating and beating faster. And in the absence of that response, the heart is relatively bradycardic. So it is not an absolute number. It is relative to the physiologic condition of the patient that we should use that as a determinant. Sinus tachycardia, over 100. Usually we don't go much over 150, and usually this is caused by something. In other words, think about, are they hypovolemic? Do they have fever, sepsis, pain? Is it exercise induced? Is it stress induced? Something causes the heart to beat faster than the intrinsic pacemaker. And that intrinsic pacemaker goes up to about 100. We can think of that as normal. Beyond that, it's a little bit abnormal and we want to know why. So we should start to look for causes here as to why that's happening. Again, we don't want to treat the rate. We don't give this person a beta blocker, a calcium channel blocker. We don't make them vagal down. And that's because the rhythm is responding to some insult, and we don't want to take away that compensatory mechanism. So next, let's take a look at this rhythm. Oops. Supraventricular tachycardia, and we're going to say, are there any P waves? We don't see them, right? No P waves. This is a T wave. So sometimes that can be confusing, especially if the amplitude is lower and you can think it's a P wave. But we need three distinct waveforms, a P, a QRS, and a T. This in this case is a T wave. The P wave could be occurring and it could be buried, or it could just be absence. If this is truly originating in the AV node and there is no sinus input, then it could be absent. The PR interval obviously is very difficult to determine. The rate is greater than 150, and the really important factor here is that as you get a history and physical exam from the patient, there's no cause for this rate to be tachycardia. They were sitting at home watching TV and now they felt these heart palpitations, and this is what you get. There's nothing to tell you they're not sick, they don't have a fever, um, they didn't run up a flight of stairs. This is something to give consideration to. So we're looking for, outside of any physiologic causes, the rhythm is regular. It's originating above the ventricle because you have a narrow complex. That's how we determine that. Um, and various things can cause it or influence it, especially if somebody is taking some kind of medication or drug, stress, lots of caffeine, no dose, anything like that can cause SVT. The key is that this rhythm creates a physiologic response. It's not the physiologic response that creates the tachycardia. In this case, it's the rhythm that creates the symptoms. So, dizziness, palpitations, nausea, shortness of breath, any of those things can be associated with supraventricular tachycardia. When we go to treat it, we want to treat it with a variety of medications that may or may not work. So you may have to go on to a secondary medication. So you should always give some thought to what's my best option here. Adenosine is a drug we think of a lot of times first because it has a very short half-life and it works directly on the AV node by stopping conduction through the node and allowing the intrinsic pacemakers of the heart to take over again. Now, that is the equivalent of chemical cardioversion. When you cardiovert someone, that's kind of what happens. It just happens with electricity. Adenosine does that chemically. The other thing that you can do, you can give some beta blockers or a calcium channel blocker. A lot of our patients that we see that have heart conditions are on a metoprolol or diltiazem. One an example of a beta blocker, the other an example of a calcium channel blocker, because what they do is their receptors are in the node and they slow conduction through that pathway. Amiodarone and procainamide can be used for this. They're typically not the first choice. The exception that I would say is if somebody has Wolff Parkinson White, if they've known and disclosed that they have this condition to you, then you should avoid the beta blockers, calcium channel blockers, and the adenosine because they have problems with their pathways. And this is a much more complex discussion for a different time. But understand that amiodarone and procainamide slow conduction through all of the pathways, where beta blockers, calcium channel blockers, and adenosine work on a specific pathway, which is the AV node. So there are reasons to go to amiodarone or procainamide first line. If they are profoundly unstable, you would go immediately to synchronized cardioversion. That means they're hypotensive, so signs of shock, maybe an altered mental status. And synchronizing again is important to avoid the R on T, which can put someone into ventricular fibrillation. In stable patients, if you have time, you can try Valsalva techniques. They may work. There's a variety of different techniques that you can use. And the longer someone's been in a rhythm, sometimes the harder it is to convert them. Valsalva techniques vary from abdominal pressure to carotid sinus massage to having someone just bear down. Before you start with carotid sinus massage, however, you should listen for bruit. And in the elderly, you should probably avoid that technique. And there are specific ways to do that correctly. Again, not one of the primary things we're going to touch on in this discussion today. Just realize you cannot go and rub somebody's neck on both sides at the same time that's 70 years old, because bad things can happen. So I would say stay away from it if you aren't fully confident in your ability to understand some of those complications. Next rhythm, let's take a look at this. There's no label to it. So now we should have some critical thinking as a part of what we're doing. Let's take a look. P waves, does anyone see a P wave that's discernible and repeats itself? Sorry, so no, there are no distinct P waves. It's a fibrillatory process. The atrium has multiple foci that are firing. None of them are firing in an organized fashion to cause a contraction. So because there's no P wave, there's no discernible PR interval. The QRS rate varies because it just is firing as conduction gets through the AV node. So this is where we can have some complication with folks not understanding the rhythm and what's going on and the therapy they try to administer. So inevitably, somebody's going to say, oh, they're an AFib, they need to be cardioverted. Well, AFib at the rate of 70 is a normal rate, and they may be perfusing just fine, and they don't need therapy. On the other hand, someone can have AFib and have a rate of 40. Again, cardioversion would do them harm. That is a bradycardia. Can AFib manifest itself in the form of a bradycardia? It can. It doesn't happen very often. But if that patient is bradycardic, their heart rate needs to be faster. So cardioverting AFib really only applies to when you have an unstable patient with profound physiologic symptoms, and we can assure ourselves at some point that they haven't had it for an extended period of time, because we certainly don't want to cause additional complications. And we'll talk a little bit more about that in just a minute. So here's what we see. Both atrial rates, ventricular complexes are irregularly irregular. So you can't predict when the next beat is coming. And so even though you have some that look like they're pacing out and they're equidistanced apart, you're going to have this variability that's not predictable. And that is the classic telltale defining moment for someone calling a rhythm AFib. The pacemaker, again, as I mentioned, is various sites in the atrium, and then we lose this atrial kick. Just to touch on this comment, and this is why we don't immediately, for somebody who has long-term AFib, we're really concerned about how we treat them. And that's because the atrium starts to fibrillate. It doesn't effectively squeeze. It doesn't evacuate the blood in the atrium. And remember, blood comes into the atrium at a very low pressure, and therefore it's not pushed through. And so it can pool in there and cause a clot. And so we're really cautious about cardioverting some AFibs, because if the atrium squeezes all of a sudden and evacuates one of these clots and it puts it into central circulation, then we could have some complications of that. In other words, we could have a stroke. So that's one of the reasons we're really kind of cautious with AFib. And often we choose to slow the ventricular response. Remember, the ventricular response is the critical component to this. So if that's going at a normal number between 80, 70, 80, 90, then we really don't treat this rhythm. We really are treating the rapid ventricular response that causes physiologic symptoms. It causes shortness of breath, and that's because we don't have adequate filling and adequate perfusion, and cardiac function is compromised. And we can treat that with any number of medications, beta blockers, calcium channel blockers, and then if we needed to, we could go to a procainamide or an amiodarone. Remember, each of those are negative inotropes, and so in the presence of heart failure, we want to be cautious giving those medications also. AFib, I would arguably say, is the most common rhythm in the elderly and probably the most complicated to treat. A deviation of atrial fibrillation is something called atrial flutter. And that's because what we see here is the P wave is in a sawtooth fashion, and that's defining for atrial flutter. And this can occur because the P wave is firing at a rate of about 300. Um, Usually, when someone has a heart rate of 150 and stays on 150, regardless of what you do, fluid boluses, things like that, one of the things to think about is a flutter because it doesn't have a lot of these sawtooth waves to define it as a flutter. But when a rhythm is fixed at 150, that atrial rate is usually 300, and that becomes a 2-to-1 block. Only every other one is perfusing or conducting through the complexes. So that's one of those flags for you when you see somebody that's got a rate that sits right at 150. One of the things to think about is, do they have atrial flutter? So sawtooth, that's kind of the defining thing of flutter. It we PR interval can be difficult to measure, and it also may vary because you can have a varying block. If you look over here, you can have a 2-to-1 or 3-to-1 or a variable block. 3-to-1 means that you have 3 atrial beats before you have a QRS complex. So this could be an irregular rhythm if you think of it that way. So how do we treat them? How long has it been going on? Again, we talked about this because of the concern for cardioversion, and we may do cardiac consult. We may give them medication just to slow them down, amiodarone, metoprolol, diltiazem them, and then if they're profoundly unstable, synchronized cardioversion. Okay, so whoops. Let's take a look here. We got a little sidebar here that we haven't had before, so it's a little something to look at. So let's just take a look at this rhythm. What do we see distinctly here? We see no P wave, no P wave, and we see a narrow complex. So we're going to go into this. Do we see a P wave? No, we don't. Does it necessarily mean that the P wave in this particular setting doesn't exist? We're going to talk about these 3 iterations of this rhythm, junctional rhythm. The PR interval can be prolonged, but a lot of things can happen that make these 2 components a little bit odd and different. Because it's coming from the junction, earlier, remember, we talked at the rate being between 40 and 60, because that's firing from the AV node. It can be regular. So here's what happens. The P wave is retrograde. So remember, let's talk a little bit about conduction to understand what retrograde means. And that means typically it flows from right to left or left to right. When you look at conduction, there's a distinct flow pattern of the electricity. Retrograde means that the beat is originating in the AV node and it travels backwards up the pathway. Because it's traveling in a different direction, it is retrograde and has a negative deflection as opposed to having negative deflection here as opposed to having a positive deflection as normal. No P wave, as is also seen in this rhythm tracing, because the atrium isn't firing at all. Everything is coming from the junction. And then there are times when the P wave fires after the QRS complex. So you have this firing, again, retrograde conduction happening here. So what can we do for it? These folks inherently are usually bradycardic. The AV node is the second pacemaker of the 3 in the heart, and it means that the SA node has failed in some way. What are some of the things that can cause this? Is again conduction system failure, A lot of times post-resuscitation, it's not uncommon to see a junctional rhythm because it takes a time frame for the SA node to recover from multiple defibrillation attempts. So you may see someone whose post-arrest rhythm or their ROSC rhythm is junctional because the SA node just hasn't kicked in yet, needs a little bit of perfusion before it does. This can also be caused by various medications and influenced, as noted here. And again, what you're looking for is why is this happening? What are some of the causes? If they are bradycardic and hypotensive, they may not respond to medication therapy, so you may need to use transcutaneous pacing as a treatment. Here, we're taking a look. We're starting to get into the blocks. Arguably, I'll tell you, memorizing blocks is almost impossible to do. You really have to intrinsically understand what's going on with blocks in order to be good at them. And it always has to do with the PR relationship. If you can describe this rhythm, the PR relationship, then you should be able to discern what a block it is or which block it is without even looking at the rhythm. So in this case, what do we see? Do we have a P before every QRS? We do. Are they regular, happening kind of on a regular interval for each beat? Yes, they are. The PR interval, however, is greater than 0.20 seconds, and that means that it's greater than one of the larger boxes here. So it starts here, and if you notice here, 1, 2, 3, so it's probably 0.32 seconds. And that is the defining moment right there, this distance, this pure interval that causes it to be first degree block. Um, what's unique about this? How do we treat it? Not a lot. It's dependent again on the R wave and how fast the rate is. So if their rate's 70, first degree block doesn't oftentimes mean much. They've just got a delay in this conduction, in this travel time of this pathway. If it's bradycardic, we're going to manage it as if we would manage a bradycardia. It should be responsive to atropine. We'll talk a little bit about that in a minute. And there is maybe a little bit of literature out there that says folks that have first degree block may be prone later in life to AFib. And that just tells us why, because there's a problem here with this conduction between the SA and the AV node. So treatment, it really depends on the ventricular rate and if that's fast or slow or what's going on. A lot of times it could be physiologic. If it's slow, we can treat it with atropine, but it really is related to. And think of it a lot of times like you would sinus rhythm. Is there something that's causing it to happen? So as we progress down the blocks, second degree block here, second degree type 1 is defined, and you can see the highlighted area here, that the lengthening of the PR interval until we have a non-conducted P wave. So this P wave has relatively normal look. This one's a little longer here. And then right here we have no R wave. It fails to conduct through until we have another P wave and it conducts through. So this is a timing issue. So one of the things to think about is the P to P interval here is constant. So every P is equidistanced apart. So the, the atrium is firing fairly regularly. The response, however, because the atrium fires and the R wave misses here, and there's a non-conducted beat, you're going to have these grouped beat sets. So that's one of the defining characteristics of second degree block, both second degree type 1 and second degree type 2. And that's where you have these beat sets, because these R waves, you have 3 R waves here together, you got 3 R waves here together. So you have these group beat sets. So by physiology, second degree block is always irregular. But it is, in this case, predictably irregular in this particular example. Still looking, nobody has any questions, so we're kind of keep moving through here. One of the things we want to think about here when it comes to treatment is what are some of the things that can cause it? Acute coronary syndromes can certainly be a cause. What can we do to treat it? Atropine. And why? If you think of this rhythm, it's occurring more proximal in the SA-AV node conduction pathway, and that part of the cardiac pathway is receptive to atropine because it's influenced by vagal tone. So since it's influenced by vagal tone, atropine is a drug and could be a very first-line drug and should be effective in the management of a bradycardia as a result of second-degree type 1 impairment. If the patient's unstable, one of the things to always consider and have in reserve is the idea to go immediately to transcutaneous pacing. And ACLS algorithms also allow for either an epi drip or a dopamine drip if you don't have pacing immediately available or if one of those is easier to come by. But most often, it's a lot easier to put pads on and immediately go to pacemaking to the transcutaneous pacer if somebody is unstable. So here, we have another block as we progress down the sick pathway. This gets a little bit sicker. The patient typically is a little sicker. The conduction system of the heart is a little bit more impaired because this process is going on more distal in the AV nodal conduction pathway. If you think of the AV node, I always thought of nodes as round, but if you think of the AV node as elongated, type 1 occurs more proximal in the conduction pathway. Type 2 occurs distal to the pathway. It's closer to where we may see third degree heart block. And so a lot of times this QRS complex can also be wide. So this can have a wide morphology. So what we look for is this PR interval again, which is necessary to understanding blocks. And what we see is this PR interval is constant. It's constant, it's constant, it's constant, it's constant. So for every conducted beat, we have a constant PR interval, but we also have these P waves with no conduction. And so again, what you see, you have group beat sets, get another classic or a hallmark of second degree block. And these P waves may vary. So in this case, you have one P wave without a QRS. In this case, you have two. So it is indeed bradycardic. It is a sicker heart. That's certainly something to be aware of. These patients tend to be sicker. Uh, and this is the reasoning and some of the logic behind this. Use the example of turning on a light. This is when you don't know whether the light's going to come on or not when you flip the switch. So there's a degree of uncertainty that makes it a little bit more alarming. What you know is that if you flip the switch, the light's going to come on. What you don't know is whether it's going to work or not when you go over to it. And so that creates and should create a little bit of more alarm for you as the patient condition. So we want to be concerned about that. What can we do? Some folks will be okay. We want to monitor their physiologic state. You can try atropine. There gets to be some nuances here with this and recommendations. In other words, and this gets a little bit more complex, a little bit deeper than if you don't understand this piece, just kind of hands over your ears kind of thing. But if the QRS complex is narrow, this is kind of a defining moment here for this, and that is if the QRS complex is narrow, the origin of this arrhythmia is a little higher or a little bit more proximal in the conduction system, and that it may be influenced by vagal tone. And that's why we say it's safe to try atropine, because vagal tone may influence it, especially if the QRS complex is narrow. When the QRS complex is wide, it's further down in the conduction system. It's more distal, and it's less likely to be affected by the use of atropine or vagal vagal tone. we can go to an epi drip or a dopamine drip. And again, transcutaneous pacing we should be putting pads on and be ready to go if this patient decompensates. Um, so here's our last block, third degree heart block. And what do we see? This is probably the easier rhythm to discern, because if you know what you're looking for, then let's take a look and look at P waves. We have a constant P. There's a P wave here, which is what you don't see, but you have to kind of envision it happening because you have another one here, you have one here, and you have one here. You don't always see these. So what you should do is map your P waves. So if you can map these two, map this distance to this point here, and then map this distance, then you'll find that these will map out. So the P to P interval is constant. And that means that the atrium is firing, it's firing normally. The R to R interval is also constant, and it's firing and firing normally. What's happening, however, is that there's no relationships. So what's happening at the SA node and what's happening in the His-Purkinje system are mutually exclusive. There's dissociation, and that is a complete heart block. So the path, the conduction of the electrical impulse is blocked. That's where that sort of comes from, or AV dissociation. So what we're looking for is a constant R to R, a constant P to P, and no predictable P to R relationship. And when you get to the finer points of this, you'll even appreciate that this P wave cannot conduct this R wave because the PR interval has to be of a finite period of time, because we know it can only travel that SA AV node pathway in a certain period of time. And so when you have a PR interval that's very, very small, chances are that this did not conduct this beat. That's kind of difficult to understand. We've got a lot of other ways to tell that this is complete heart block. And because it's typically um, kind of the final pacemaker left in the heart, we want to be ready to pace. We've got to be able to treat these folks. Can you try atropine? You can. But again, atropine works best on the SA uh, proximal AV node uh, dysrhythmias, and this is AV dissociation. So it's you can try it, but it's probably not going to do anything. You really should very quickly be prepared to go to transcutaneous pacing. You can use dopamine or an epinephrine drip if those are immediately available to you. But again, usually you can do the pacing before you can do either of these and get them set up and get an IV and all those things. Okay, let's take a little look at this. Um, are there P waves? Wow, there's just so much electrical activity here that's profound. And that means that it's coming from the ventricle, that you couldn't tell they're P waves if they were there. Um, and if they are, they're dissociated. So there is no PR interval. The QRS is wide, which tells us this rhythm is originating in the ventricle. And it is usually fast in this particular case because each one looks like the one before it. They're called monomorphic. If these were each of different morphology, it would be polymorphic. And this is a variety of VTAC. And so as we get older, we don't do well with tachycardias, especially ventricular tachycardia. And so while some of these patients may be stable, some of them may be stable. They may come in and say, hey, I don't feel right, check my blood pressure. Next thing you know, they're in VTAC. Those are the exceptions. Most adults, especially as we get older, don't do well with VTAC. The rate is too fast to allow for adequate filling, and therefore they become unstable and symptomatic. Now, monomorphic versus polymorphic. Monomorphic means that the origin of the dysrhythmia is in a single focus. Polymorphic means that it's coming from a variety of foci in the ventricle. Torsades is an example of polymorphic VT. It's a subcategory. And it is indeed profoundly unstable, if at all perfusing. So torsades is one of those things we see with folks that have hypomagnesemia or long QT. And again, we're getting a little bit more complex than where we are today with this particular session. So common ACLS medications, amiodarone, if they are stable and can tolerate it, we can use amiodarone or procainamide because these slow conduction through all the pathways of the heart. They work well on the ventricular arrhythmias and are relatively safe to use in the presence of like VTAC that's stable. If the patient is unstable, they're hypotensive, they've got signs and symptoms that are serious, we should go to immediate synchronized cardioversion. And here's where it gets a little bit confusing. Is whether we have polymorphic VTAC, we may need to asynchronously cardiovert, and there's absolutely no difference other than the term between an asynchronous cardioversion and defibrillation. Those are both one and the same because we're not synchronizing off of an R wave. Because of this polymorphism, we don't have an R wave that we can cue in on to time the shock. In addition, polymorphic VT by definition, is more unstable than monomorphic VT. That doesn't mean that someone that's in a monomorphic VTAC is more stable. It's that polymorphic VT is a sicker, more irritable heart, and those folks can decline much quicker, and we need to be prepared to immediately deliver electricity. And again, the thought of delivering electricity is to stop everything that's happening to allow the intrinsic pacemakers of the heart to take over. And someone asked if we're recording this, and we are recording it. So we will be able to send it out again, and we will post it so that you can go back and look at it again. And certainly, if you have a question about anything when you're reviewing it, you can send me an email, and I'll be happy to help you work through anything that might have been confusing. So here we talk about stability and cardioversion and shortness of breath and the therapies that we need to think about. Stable can be medications. Unstable is going to be immediate cardioversion, synchronized if it's monomorphic and you have discernible R waves. If it's polymorphic, you want to go to an asynchronous cardioversion. I tend to use the word cardioversion because that's a word I should always want to associate with perfusing rhythms. I try to use the word defibrillation when I'm thinking about dead. And we'll touch on that in just a minute as we progress down our pathway. So arrest rhythms, asystole, ventricular fibrillation, pulseless VTAC, and PEA. We're going to get into those. Take a break for just a second. Okay. Jokingly, this is the most stable of all rhythms because once you've hit this one, you're not going to have any others. And so asystole, this is flatline. Lots of things to think about here. And that is that you see no electrical activity or very minimal electrical activity, which is an agonal rhythm. If you were to see an occasional electrical impulse, it would be construed as an agonal rhythm. But asystole is flatline. You have no P waves, you have no interval because you have no R waves. And the key here is that in out of hospital cardiac arrest, the prognosis here is very poor. In hospital cardiac arrest, this could be an end stage rhythm. And usually, when folks progress to asystole, they're progressing in the wrong direction, obviously, and very difficult to reverse this and have purposeful recovery. There are with a caveat again, maybe something we don't touch on in a lot of detail. There are specifically some sudden asystolic events that do have from a Stokes-Adams event or something like that where the therapy may be different and the etiology of this sudden asystolic arrest is very different, and it can be treated very differently, but that is the exception. For the purposes of ACLS and what we typically see, asystole is an ominous rhythm that has a very, very poor resuscitation rate because the heart's lost all of its electrical potential. So the key to treating it, even though we don't always do very well with it, there may be some keys to reversing asystole, and that is that we should immediately look at the H's and the T's. Why did it happen? The only medication that we give in asystole is epinephrine, and there certainly is presently no recommendation for electrical therapy. There's no reason to pace it because it has no electrical potential. Defibrillating it takes away electrical potential, so that's also counterproductive in this rhythm. The only other medication that you may give in this is as a result of finding an H or T that's treatable. So that's really important. The classic ACLS drug is only epinephrine, unless you're treating an H and T. And that's important because a lot of times when we get to this point, folks think, well, I've done everything else, I should try something. And that's more of our mindset than it is beneficial to the patient because just empirically giving medications may not be helpful and can actually be harmful. So we should have a reason to give a medication. One of the drugs to think about is calcium, for example. Okay, somebody's in asystole, we've tried everything. Hey, do you think we should give some calcium? Well, calcium, in the eyes of the American Heart Association and science recommendations, is a class 3 drug, which is known to be harmful. So unless you're treating a calcium channel blocker overdose or there's a reason to give it, it has not shown value in the resuscitation of an asystolic event. PEA. So PEA is kind of interesting. Pulseless electrical activity, PEA, and asystole are both managed exactly the same, and that is that we want to focus on the H's and the T's. The difference is that PEA has some discernible, purposeful, organized electrical activity. It is not ventricular tachycardia or VFib, so it's not a shockable rhythm. And we do not palpate a pulse with it. So pulseless electrical activity, for folks that have been around years and years, this used to be called EMD, or electrical mechanical dissociation. And if you take that and put it in the context of PEA, that's a subcategory of pulseless electrical activity. So what are the keys? The keys are the things that make the heart not squeeze. So in PEA, we have an electrical system. It's firing, but the heart and the ventricle isn't squeezing. So why? What causes that? Well, no volume can cause that. Hypoxia, acidosis, potassium imbalances, hypothermia, which make the muscular activity of the heart ineffective, toxins. Then we get into three of the T's are actually obstructive causes of PEA. Cardiac tamponade just puts so much pressure on the heart that it's not able to squeeze effectively. Tension pneumothorax does the same, and a pulmonary thrombosis just doesn't allow for blood flow to get through to the heart, and it doesn't allow any cardiac filling. So these three, 1, 2, 3 here, are obstructive processes. Cardiac thrombosis just interferes with the function of the ventricle because it's not being perfused. That's just somebody just had a big MI, and it can be one of those causes. But identifying these that are treatable, overdoses in particular, hypoxia with ventilation, hypovolemia with volume, um, potassium, if we've known to have pre-existing conditions, acidosis, renal patients, for example, any of these things that we can treat quickly may reverse PEA or asystole. So the key is treating it, volume, give them a couple liters of fluid, oxygenate, ventilate. The only medication we use is epinephrine. There's no indication for electrical therapy here, and there may be some value if we can do an ultrasound to assess wall motion. Some PEAs have wall motion, which is contrary to other PEAs that have maybe no wall motion at all. And this may be a reason to withhold resuscitative efforts in particular. With no wall motion, those outcomes can be poor. With wall motion, if it's purposeful, they need volume, and we need to try to figure out the cause. Because the heart's still trying to squeeze, you do still have some muscular activity, and we may be able to work on that. Lastly, as we get down to some of the final rhythms, VFib, which is kind of the classic out of hospital scenario that we hear about with AEDs and all of that. And that's just where the heart is fibrillating. It's the equivalent of a seizure. It's not purposefully squeezing. It has no P wave. It has no PR interval. It has no QRS. It's chaos. It's electrical chaos of the heart. And again, what we want to do, if we don't quickly start CPR and immediately defibrillate this, defibrillation is key, because what it does is it stops this chaotic electrical activity with the hopes that we're going to restart with the intrinsic pacemakers of the heart and reperfuse. So the key is defibrillation. Remember that ventricular tachycardia can also be pulseless. Can also be pulseless, and it's managed like ventricular fibrillation. The only difference is when you do CPR at the end of the 2-minute cycle, you'll need to stop and check for a pulse. If the rhythm is organized ventricular tachycardia, then check and see if it's perfusing, because that's a rhythm that could be perfusing, and if it was, we'd manage it a little differently. Medications, epinephrine, usually somewhere at the second shock. And that's because if the first shock was effective, it's not someone we necessarily want to give epinephrine to. So we usually wait to determine that that first initial shock was ineffective. And then when we identify that VFib persists, we give epinephrine. If we've shocked it a couple of times and we still identify persistent VFib, then there's an indication for amiodarone or lidocaine as an antiarrhythmic therapy. The key here is defibrillation. Shock it as soon as possible. Do your CPR for 2 minutes, reassess, and shock again. That sort of summarizes our piece on rhythm recognition. You need to have a consistent approach. If you apply your techniques the same every time, you're much more likely to be successful. And knowing the etiology and the electrophysiology of the event allows you to optimize your therapies and hopefully optimize the outcome of the patient. Thank you very much for your time today. And I have no questions at this time. If anybody wants to pop in with a question, we'll allow a couple of minutes for that to happen. And Lucian is putting up my email address for you if you have questions outside of the chat window. And we are right at 1 hour. I don't know that I could have planned it any better than that. And having not had it rehearsed, I think it's pretty kind of interesting that it finished up just like that. So thank you all for listening in, and we will have this as a recording.